Welcome to Health Tech Heroes, where we talk to innovators who are rewriting the DNA of healthcare. Today, we are excited to welcome Megan Smith, Vice President of Revenue Cycle Operations at Boa Vida Healthcare. With over 21 years of experience in hospital revenue cycle management and strong background in patient financial services, AR management, and analytics, Megan brings valuable insights to healthcare operations and process improvement. Welcome to Health Tech Heroes, Megan.
Thank you. Thanks for having me.
I am really excited to have you over at the podcast. First of all, we are Health Tech Heroes podcast, and I love to hear your origin story. What brought you to revenue cycle management industry, and what made you to stick around and do such amazing work in the revenue cycle management?
Yeah, sure. So I have been in the industry for over 23 years, actually, in March. And a while back when I started, it was just a job. It was a good paying job, and it was something that felt secure. I was in my 20s. And then as I started to work in revenue cycle and saw how it's very detailed, there's a lot of moving parts and there's a lot of room for improvement, I stuck around. My first leadership role was actually in 2005, so just a few years into my tenure of revenue cycle. I quickly moved up from there into client management, loved the metrics and the measuring part of it. I've actually done 50-50 in my time with revenue cycle, 50% in the vendor world, and then the other half is really on site directly working at a hospital, which I think gives me a unique background and insight to, how we can keep costs low. So from my experience in the vendor world, how can we keep costs low by doing that process improvement, looking at those metrics and seeing where we can, shave off some AR days, reduce our denials, that sort of thing. And then also on the hospital side, that really helped me to kind of connect to the purpose of why we're doing this work. And really, it's not just, collecting money and getting those claims paid. There really is a patient at the other end of that account number, and just the cost savings that are required when you work directly for a hospital. It's just a different look as opposed to being at a vendor. At a vendor, you want to be lean. At a hospital or at a physician's office, you're required to be lean because certainly you're never going to be reimbursed what the cost is for seeing patients.
That's a really good experience that you have, like 50-50%, right? Where you can, at the vendor side, where you're really trying to cut the cost, and then you have 50% in the hospital where you're really keen on the patient outcomes as well. Was there a moment within when you were there on the patient side and you're seeing firsthand how your decisions actually impact the patients? Was there a patient that you remember or an incident that you remember that said like, okay, I'm doing the right thing being in this field?
Yeah. So there have been several situations. Probably the earliest started back in my customer service days. So in 2005, like I mentioned, when I moved into a supervisor role, that was actually to open up a contact center. So self-pay, customer service, the folks that you get on the phone with when you have a statement and you have questions. There were several patients, especially being a supervisor, that were escalated to me, whether they were unable to afford their bill or maybe things weren't calculated correctly or paid correctly by their insurance. So when I think about stories, I can think about several patients that I've talked to, but I think more so in the departments that I've worked at. So I've helped several patients through, navigating their benefits when I was in the customer service self-pay side of things, answering the questions that they had. Why did the insurance, charge this way? It's almost a secret language that we have in the healthcare industry, in revenue cycle, when we talk about deductibles and co-insurance and allowables and just all of these buckets. And what that means to the patient is a bill. And they don't know how to break down what the contractual rate is and why did it process as out of network and why does this bill look bigger than last year when they saw the same provider. So I've helped a lot of patients navigate through that and kind of give them that education on what those buckets mean, why the insurance is saying it's this much out of their pocket, what they can do to maybe reduce that by going to an in-network provider. And there were those situations. And then also when I moved into from the vendor world with my first role, moving into directly my first experience at a hospital directly, we had a department that was specific to audits and appeals, and I led that department. And this was not only really fascinating work for me because I love a good problem. I think that's part of that process improvement passion that I have. So really putting that puzzle together for these patients to make sure that they got those claims paid, because a lot of times the patients would seek that care, and this still happens today. It's the care that's prescribed to them. The physician needs them to have this, procedure, whatever it is. The insurance company has a different idea, and so how can we advocate for that patient? And that's what that department really did, was after the patient was seen for that service, if the insurance still denied, even though maybe we had an appeal or an authorization up front, and then they denied when they got the claim because they didn't feel it was medically necessary, how can we fight that and really tell the patient's story through clinical documentation, through really just kind of carefully worded appeal letters? And myself and my team, we were very successful in those. The team did a fantastic job putting together those appeal letters, and we were able to advocate for the patient in that way.
Yeah, there are basically, this is where I think the health tech hero comes in. You use the word both advocate and fight, fighting for the patients and advocating for the patients. I think sometimes you have to advocate, sometimes you actually have to fight for the patients. So it's a it's a great way, and I think there is a fine line where when we can use those. I would love to dig a little bit deeper in this. Can you explain a difference between where you fought for the patient and an advocate, or it was some words that naturally come to you?
Yeah, so there are situations where we can advocate for the medical necessity for the patient. We do
Yeah.
that up front sometimes. Well, it should be, in the grand scheme of things, it should be done up front prior to the patient receiving that service. We advocate for the patient, even if it is something that the insurance considers an experimental, or maybe the patient didn't do the conservative care first, but they jumped straight to something a little more in depth, maybe like a surgical procedure without the physical therapy or the NSAIDs or any of that stuff. Our providers can advocate for the patient, and our front end registration staff can advocate for the patient to try to get that service scheduled. It's really important to the patient, sending all those clinicals, the appeal letters, that sort of thing. We can do it up front. The fight is what comes in on the back end. So the advocating in my mind is that we're trying to get it authorized, we're trying to get the green light. And then what happens sometimes, and more often than the insurance companies may admit, is even if we get a pre-service authorization, the patient goes and gets the service, and then on the back end we get a denial on our claim. And that's where the fight comes in. And that's where, we use that terminology that we provided that service in good faith with the pre-service authorization. And then, we do throw in some more of that medical necessity language to prove that, yes, this really was a procedure, clinical documentation and the decision making of their provider. This was a necessary service for the patient. So some insurance companies, when they deny these claims, they say it's all provider responsibility, but sometimes they say that it's patient responsibility. And the last thing that we want to do, especially if it's one of our providers that told the patient they needed this service and then provided that service, really the last thing that we want to do is send that entire bill to the patient unless we've gone and we've fought for it. We'll do our best to try to, get what's right for the patient.
Thank you for differentiating that. I appreciate that. There are three words in the previous to previous question. There were three words that you had used. It was copay, co-insurance, and allowables. Can you explain these three differences?
Absolutely. So there are actually three buckets that a patient will see on their EOB, and it's common language that you see when you look at your benefit documents and you try to decide the level of insurance that you want. Most of the time, the insurance company is offered by either your employer or a marketplace insurance, or maybe you're just somebody like a Medicare aged patient and you're looking for maybe getting a commercial or a Medicare Advantage plan. You've got your copay, and that's just the standard amount. You'll see it on your card. It's a standard amount that you have to pay every time you go and see a provider. So it's usually something like $20 for a doctor's office, $50 to $75 for an emergency room. And that's a right off the top cost that you have to pay every time. Sometimes the ED copay is waived if you're then admitted inpatient, but typically you have that copay every time you go and see a provider. Next, you have your deductible. And your deductible is that bucket of money or that amount of money that the beneficiary, the subscriber, must pay before the insurance benefits kick in. So if you have Nowadays the deductibles, are 2, 3 times what they used to be, especially when I started 20 years ago. A lot of times deductibles were only about $500, or sometimes there weren't any deductibles. So nowadays we're looking at more like in the 3,000, 5,000 up to $10,000 deductible range, because it's the higher deductible. It's kind of like with your car insurance. The higher deductible, the lower your premiums are typically. So people are kind of choosing to do these higher deductible plans to kind of ease, some of that cost for the premiums. So your deductible is what you pay out of pocket when the claim is processed prior to the insurance kicking in and paying any benefits. The allowable is actually trying to explain. Allowable is something that most patients don't actually have visibility to. Allowable is kind of revenue cycle contractual language. And what that means is the allowable is basically what the insurance has designated as the amount that they will pay for that charge. So if they have an office visit, so say it's just like a level 3, 99213 office visit, the allowable for that office visit, doesn't matter if I bill $500 for that visit, the insurance company's allowable is $200. That's the most they're going to pay. Your deductible is based off of that allowable. So if you have a deductible of, $5,000, they're not going to, and let's say it, go back to that example of a $500 office visit, the insurance company, if you haven't paid your deductible, is not going to require you to pay the full $500 charge for that doctor visit. They're only going to make you pay the allowed amount for that doctor visit. So you'll be given that $200 bill in that example. Most of the time you don't see allowables. Like I said, it is a contractual rate. There's also things like fee schedules and all of that. On the back end revenue cycle side, getting a claim paid and making sure it's paid appropriately is really complex. It's overly complex. A lot of patients they don't see that side of it. So when we throw around that language, it does get confusing. The last bucket that I want to bring up that I actually didn't talk about before was coinsurance. So that's another one of those 3 main buckets that the patient is responsible for paying. And you'll see this language on your EOB. And the coinsurance is in addition to your copay and in addition to your deductible, and it's that percentage of cost share. So once your insurance starts paying, so you've met your deductible, the insurance is now paying for that. If we go back to that $200 allowable example, your insurance is only going to pay their percentage of your coinsurance for that. So in other words, most patients have a 20% coinsurance. So out of that $200, your insurance will pay 80% of that, and then you will pay 20% of that. So that's how those, kind of 3 buckets translate into your bill after a visit.
2 things that you touched upon, and I think it kind of goes to our next question and diving deep into this. You said the deductibles have increased quite a bit in the last 20 years, and
Yeah.
things are quite complex as well. How things have changed since last 20 years, including the deductible? What are the big changes that have happened over the last 20 years? And what are the negative things that have happened? And are there any positive changes at all that have come through?
Yeah, lots of things. 20 years ago when I started in this industry, it was not unheard of for especially hospital employees to have no cost insurance. No cost for them, no cost for their family. When I started working at a hospital in 2010, it was free for my entire family. We had no out of pocket. I had 2 of my 3 kids at that hospital, and they were free. So it was a different time back then. We also had less managed care. We didn't have managed care plans for our federal and state Medicaid and Medicare. So it was more straightforward. We had less authorization requirements, and trying to think of some of the other things. It was still a challenge to collect on claims, but I think we just had less hoops to jump through. We definitely had less experimental pharmaceuticals. We had less, procedures, experimental procedures, less things coming out from the FDA that the doctors want to latch onto because it's a great, procedure for a patient, but it may not be authorized or medically necessary in the eyes to the insurance. So I guess if I could kind of wrap that up and generalize it, the insurance played less of a role in medical care. So the insurance was there for us to bill. The patient received their services. There was a lot less of that. Insurance is saying what's medically necessary. Now, Medicare has always had guidelines. They've had guidelines on the limits to certain procedures. They've had, this procedure is not going to be authorized, unless you've done some of this, like I mentioned, conservative care prior to that, which would be like your physical therapies, your NSAIDs, your anti-inflammatories, steroids, that sort of thing. They want you to do those things before you get, like the facet injection or, cortisol injection, surgery, things like that. Those sort of things have kind of always existed. They grow here and there, but once the commercial insurance companies really dipped their toes in the water, then things got a little more, it's I hate to say that patient care is based on what the insurance is going to cover, but the reality is the insurance does guide what providers can and can't do for patients. If a provider feels that the patient is ready for surgery, but the insurance is saying you have 5 steps prior to that, then they're kind of required to do that. We can certainly appeal, like I said, advocate for the patient, but it really is more complex now because the commercial insurances have entered the picture. What is good about that? Well, I want to say that through this red tape, there has been a reduction in fraud, I suppose. I mean, we read those articles about how providers are billing, Medicare especially, because Medicare doesn't do a whole lot of prepayment audits. They do audits after the payments have been made, but they don't have a lot of funds to handle that administratively. So we don't get as many audits probably as we should for Medicare, straight Medicare. So I would say that may be a good thing. Other than that, I mean, honestly, not to completely say that not to say commercial insurances are awful. By and large, I think they have good coverage for their patients. They just add a whole lot of red tape. It's just a lot of hoops to jump through. And I think what that translates to on the back end is claims are not getting paid. Patients are, because they have, higher out of pockets, patients are delaying services and medical care that they need. Maybe they're not even getting medical care that they should have. So, I mean, that's just made it more complex. I think the landscape, I'm sure there's things that have improved, but, kind of from where I sit, just trying to collect on these claims, I don't see a whole lot, to be honest. Not to sound like a pessimist, but
No, I mean, also you are a professional, but you're also a end user of the system, right, of the healthcare. And sometimes it is a little bit difficult to see the benefits of the changes. And always, like everything else, it is a challenge, and we have to come up with everything we have as far as problem solving is concerned. And we will solve this problem a little bit, one step at a time, and or slow down the progression towards the negative side, and hopefully start moving towards the positive side at some point. Can you share, changing gears a little bit more on Boa Vida? 3 questions for you. I'm really curious about the name Boa Vida, how that came about. And the second question is, what is that unique that you do that nobody else does? And basically your USP. And third question is, what exactly do you do? What is your strength?
yeah. So you're gonna challenge me here. So Boa Vida, I have been here since July, and I remember when I first started, I thought, what does that stand for? Because it's a very unique name. So we have 3 hospitals down south. We have Mississippi, Arkansas, and Oklahoma, and then we have several clinics kind of scattered across those states. I think our last count we had around 30 clinics, 28 to 30 clinics. We're still kind of bringing on some new partnerships. So we are smaller hospitals, critical access hospitals, and rural health clinics. And so we are able to serve kind of the underserved, the patients that have we have a high Medicaid population. We also have a high Medicare. We're able to, provide the same services as really any other critical access hospital.
And I think that is really important in healthcare, that you're doing, you want to make profits, but you're making profits doing the right thing. I think it's very important. I will keep that part, the front and the end part. Happy to get it out. No problem.
Thank you. Great.
All right. So one thing that I was curious about is, as we are going into the revenue cycle, what kind of technology currently is available, and what are you planning on implementing? How are you leveraging the current technology to make this system a little bit more efficient? I have to ask this question because I'm a health tech heroes podcast, right? We want to bring the health tech part in there.
Yeah. No, absolutely. And I'm glad that you asked. So as much as I love problem solving and revenue cycle, and there's definitely workflows that we can streamline and, fix things up front. That's always the goal. Fix it up front, because the back end revenue cycle, we're kind of the cleaners. We're the cleaning crew. There are several tools out there that you can use. There are tools that you can use that are tied into your electronic medical record system. So the system that the clinical documentation goes into. And then there's kind of some external tools. The EHR that we utilize does not have a robust work queue system. So we had to think outside the box. And the way that we did that was really just using Microsoft tools. So it's something as simple as getting some really good macros together in a workbook, understanding what it is that you want your team to focus on. And then we have created a very robust, it was refreshes on a regular basis. We do a huge refresh every Monday. It's got dashboards, it's got, call outs for aged accounts. We have a weekly snapshot where we direct the team on what to focus on. And it's the entire inventory. So we have tabs on every single account, whether it's something that is, just newly discharged or it's something that we've been trying to fight to get payment on for, over a year now. So we have all that information in there. We feed in our denials, we feed in our claim submission, we have our productivity in there. So it's an all-in-one workbook that sounds, it kind of sounds simplistic because it's in Excel, but it's got so many moving parts. And then we trained the team to filter this and to go to their weekly snapshot, find out what we want them to focus on, and then filter that spreadsheet, based on what we want them to focus on. Some of the kind of the brains behind that spreadsheet, the macros, the VBA that we built in there, we actually leveraged AI. Just some simple, we have some subscriptions. We use Chat GPT, and my teenage kids always roll their eyes like, Mom, you can't talk to Chat GPT. But honestly, obviously you want to vet the information. But when we wanted to really leverage and take it, another step into, something a little bit fancier with our work queue system, that's what we used. And we were able to tell it what we wanted it to do, and then, look at some of these formulas that we had in there and really optimize what we have. So work dates, for example, we have things that are being pushed out. We have a deferral or tickler system is what we call it in the business, so that the team is only touching accounts that they need to touch, whether it has a denial on it or it's something that, the tickler status has come due or the deferred has come due. So we've really crafted a robust ATB or work queue system that really allows the billers to work as efficiently as possible. Our team gets, anywhere between 50 to 60 accounts touched a day. This is in addition to working in the claim system and submitting claims. And so really, they're probably working close to 75 accounts a day. This includes hospital claims as well as clinic and hospital pro fee claims. So we have everything in there. It's separated. Our billers are split by the insurance company they follow up on. So their financial class, which is standard, kind of everywhere else. And our billers kind of do that cradle to grave approach where they do the claim submission, and then they're also in charge of the follow-up on the back end for the claims that they're assigned. So we were able to do that. It's worked really well. So we implemented this back in September. And since then, we have shaved off, I would say, if I were to combine all three sites, I would say close to 17 AR days. And your AR days really are that measurement, that metric, one of them, to see just how healthy your revenue cycle is. So we've reduced denials down to the goal that we're looking for. We have shaved off nearly 20 AR days combined with all three of those sites. One of the sites, especially for a critical access hospital, last month we reported 35 gross AR days, which is phenomenal for, a critical access hospital and all the clinics combined. So we have it all rolled up. So we're making really good progress. We're getting ready to take that next step and use AI a little bit more, in that we are feeding values and denial trends, and then really how to work those trends into Chat GPT, into our subscription. We've stripped out all of the PHI. There's no need to have any PHI on there. We're just including the CPT codes, the line item denials, the code the insurance used, and then really what our biller did to fix that. And what we're hoping to achieve is an algorithm that basically tells the biller, we've got this denial, this is what this denial means, and this is how you can resolve it. And it's going to be based on historical data and our success. And so we've just started doing that, but it's showing us some really good data so far. So I'm hopeful. That's kind of in addition to that, the denial prevention efforts that everybody is trying. I think I've been listening to over 20 years now. The goal is to prevent denials on the front end, and it's really hard, especially when the payers are using different codes for different things, and there isn't a lot of consistency. So I'm hoping, through this project that we're working on, that we'll be able to get a little bit of consistency on the end user and allow them to be able to resolve any kind of denial that comes across their desk. So we're going to kind of simplify the things that are coming for them.
I like that line that you have drawn where you're doing the system based on purely on data, not predictive analysis, and then drawing a line and getting the recommendation from AI saying that where we can improve the process and not necessarily have yet applied the AI for the process itself. I think it is still in an hallucinating area, and we got to be very careful with the healthcare on that. So you are using AI in the recommendation part. I just wanted to point that out. And the second thing you did mention AR, and we discussed it was the accounts receivable. Why is it such an important KPI?
So that's kind of that's our work. That is
Yeah.
100% the work. So accounts receivable, we want to make sure that our AR days are low because that means we don't have as much outstanding. So the goal is, and hopefully you can do this as in a high percentage, the claims that you bill out at the beginning of the month, you have payment in the bank within 30 days. So you're going to be submitting claims on a daily basis. You want all of them to turn around and pay within 30 days. Medicare, you'll have money in the bank within 21 days if you have a clean claim. So if you don't have any denials and you don't have anything holding up that claim in the Medicare system, then you have money in the bank within 21 days. Most commercial payers, unless it's a high dollar, hospital claim, they're pretty good about remitting payment within 28 to 30 days. That sweet spot is about, the 28 to 32, days, calendar days. But then again, I would say, so just kind of a general rule of thumb, for all the claims that you submit each month, about 80% of them are going to pay, probably without any manual intervention. Maybe manual intervention, doing some claim edits up front to scrub it and make sure it's good. Then it goes to the insurance and they process. About 80% of those don't require manual intervention. 10% of those are going to be denied. 10 to 15% are going to be denied. The rest of them, you're not going to get a response at all. You just won't get anything. The insurance didn't get it. The claim was rejected, and maybe your biller didn't check rejections. There's all sorts of things. Maybe it's a paper claim and it never made it there. About 5% of that is never going to be received, 5 to 10, depending on how many denials you get. When you compound that month over month over month, then that's when you start to get a lot of claims that are sitting out there that the team hasn't had a chance to get to. The goal is that you want to keep your receivables as low as possible so that when the claims go through and they get billed and the next batch of claims come in every day, because it's every day my billers are getting a fresh, batch of claims, and those claims need attention. We're hoping that we can get them as clean as possible so that they're just paid on the back end and they're not that kind of leftover 20%. That we have to just deal with.
Yeah, 20%, and especially the 5% which have no response at all, and you don't know what to do with those, right? We have to figure out what to do with those, then uh, do what needs to be done. And that
Absolutely.
will just keep assimilating over time if you don't take care of it right away. And thank you very much for this 101 for you, but pretty high level details for me. It was very interesting. All
Absolutely.
right. So looking at the future, I do see you as a thought leader in this space and would love to see where do you think the future is as far as the whole revenue management is concerned? Just the future, like what is it going to look 5 years later, and what kind of impact are we going to see because of the new technology, the emerging technology on your system?
Yeah. I think right now we're at a tipping point. We're at a tipping point where it's become clear, and maybe it's bubbled up even more. I know CMS is getting more involved, but the insurance companies and providers, we need to collaborate more. There needs to be more collaboration. There's a common denominator here, and that's the patient. And so right now we have providers that are stuck in this cycle where they want to provide services to a patient. They're not being reimbursed the cost that it takes to provide services to the patient, and more things are getting more complicated to bill and to get authorized. The insurance companies are increasing policies, or premiums. They're increasing out of pocket for the patient. And so it's kind of gotten to a tipping point where we need to get to how can we work better together as providers and insurance companies to get better messaging on denials, get better claim statusing. So for years, there has been this thought that you could get a claim status and not have to have a human being check on the status of a claim. So let's go back to that 5% that I said you never got a response on. Wouldn't it be nice if you got an automatic response from the insurance company website? Maybe you have like a file that you can use, and there's several files out there. They've been around for a while, screen scraping, things like that. They don't work. And I hate to be a pessimist, but they don't work. And the reason why they don't work is because the insurance companies have no consistency. There's no consistency, and there's no way for our file to go into the website for the insurance company, grab that claim status of all pending outstanding claims, and then push that information back to our system with meaningful data. It's not meaningful. So people are kind of hitting their heads on their desk, and we have been for a long time. I remember years ago we tried to tackle that with a large EHR company. We had just gone live with a very popular, Epic system. Epic's got very robust tools. The insurance companies did not allow us to get very meaningful data back into our claims. And so my billers were touching things they didn't need to. Things were just getting lost. And so you're never going to have enough billers to touch every account that you have. So most billers are assigned anywhere between 2,500 to 3,000 accounts. There's no way that they can touch every one of those, especially even if they're as efficient as my amazing team is now. They're never going to touch all of those. So we rely on automation, we rely on tools to help us, and then we hope that these are going to pay without any manual intervention. So I think we need the insurance companies to make it easier for us to just get that claim status, use our system tools, allow us to use some of these tools to get those statuses, to push that back into our system, because everything is just getting expensive. It's expensive to have the bodies manually check the work. It's expensive for the insurance companies to have their system or their people manually check things. And so now they're looking to AI to kind of, weave some of that technology into my response here. They're looking at AI, and a lot of them are using this to look at first level medical necessity appeals and to look at some of that medical data, the medical records that, providers send in. I haven't had a huge, because we're a smaller critical access, kind of system, I haven't had a lot of experience in how that AI response comes back on those claims. It's hard to tell if it's an AI written letter when they're saying no to this author's pre-auth or, whatever that is. It's hard to tell if it is or not. I just know from my end that we're continuing to, try to be as efficient as possible, try to get those authorizations, do what's right. And it just gets a little more difficult, and it's still very manual on our side here. It's the inconsistency with the insurance companies that is going to hold us back from using tools like AI or any kind of automation without having humans touch those claims. One good example is we were billing an insurance company. We had a whole batch of claims billing an insurance company with it was a clinic claim, but we had a hospital NPI. And the NPI, think of it like a tax ID number. So we were sending the wrong NPI on those claims. The rejection we got back from the insurance company had nothing to do with an incorrect NPI. The language on that rejection was nonsensical. So my biller's looking at it, and we had dozens of these, and they're like, what are we supposed to do with this? It triggered a phone call. They checked the website. It escalated to our system analyst because we thought maybe we had a problem with our system. So all of these things, if the insurance would have just said, that's a hospital or that's an incorrect NPI for this type of service, that would have clued in my biller to look at the NPI and go, oh, this isn't the clinic NPI, this is the hospital NPI. When we have that miscommunication and our crosswalks just aren't talking and we're not helping each other be more efficient and automated, until we get to that point where we're, like I said, collaborating, I think we're just going to be kind of stuck. We're going to be a little bit stuck from a workflow, kind of efficiency standpoint on revenue cycle. One thing I will say, though, that is happening more and more is CMS has been more involved with the authorization requirements, especially coming from managed Medicare plans, which I think is a good thing. And I saw several of those plans really slim down their pre-service authorization list, which I think is great. I think that's really good. I'd like to see a little more leniency in that. So one good example is we get authorized for an MRI with contrast, and then the patient comes in and then they say, actually, we don't want to use contrast, and we end up billing a code that's without contrast. The insurance company will deny that. And it's like the difference, the contrast. It's still an MRI. It's the advanced imaging that they're concerned with and needed to authorize. Why are we getting a denial? Because the code, is slightly off by 1 or 2 digits. And that's the kind of thing that I think is being nitpicky, and it's not fair. And it's kind of taking advantage of the system in a little bit. So yeah, I think 5 years from now, as long as we're doing that collaboration, I think that's the key. That's what's important, because the patients can't afford to have anything higher out of pocket. They can't afford to pay more in their premiums for less coverage on the back end. So I'm paying, for example, $600 in premiums to insure my family. A lot of people are paying that much, but then I have a $10,000 deductible because that $600 is only going to buy me, a high deductible insurance plan that has virtually no coverage. My insurance doesn't actually pay anything into that. So That's what makes it tough. And so I like to see, once we can do some more collaboration, then we can start to use some of these AI tools to just streamline and make things more efficiently, make it more automated. I don't want to have less billers. I think I'm always going to have the same amount of billers, but let's have them focusing on things that they need to focus on. There's still a significant amount of aging that we just lose sight of. And unfortunately, we have to write those off. And that happens everywhere. And it's very frustrating that there's so much back and forth with the insurance, and we're not working as collaborative as we could be, so that we end up at the end of the day having to write things off as an organization because it's untimely or, several of other reasons.
This brings me to this question, and I'm not sure if there is a short answer for this, but
Yeah.
I'll present the question to you anyway. Isn't there a slight perverse incentive for insurance to not work with you because it's making you write off the 5%? Is there any incentive for the insurance to work with you on this? Because at the end, if all the claims are properly processed, they might actually end up paying more.
Right. Yeah. No, there isn't. I think the incentive would be we're connecting back to the purpose, and we're doing it for the reason why we're here. And that's for the patient. We're here for the patient. I have always said that I don't think that healthcare should be a place where people get rich. I think that there's a calling for our medical professionals, and they do it or should do it for the love of helping, being that person to care. I know a lot of nurses, I know a lot of doctors, and they're there for that purpose and that calling. If an insurance company has a profit of billions of dollars, something's wrong. I don't think that that's appropriate. I think that, at the end of the day, we have to do it for the patient. And if we were to work better together, I mean, who knows? The insurance company's not paying our claims causes us to drive up our charges. So now we're doing this, back and forth because we've increased our prices. Then the insurance company has to increase premiums in order to pay for those prices. And then we have to increase because we have too many denials and we're not getting reimbursed. And so we're in a vicious cycle right now. And I don't know what the answer is other than I think we need to collaborate better. If we're doing the right thing and the insurance company is doing the right thing, I think that, the patient's definitely going to benefit. We're going to have probably healthier patients in the long run. And maybe that would be less visits too. That's something to maybe consider. There's people with much larger brains than mine that could probably figure out what that solution is. I just think that collaboration is an important piece.
That's a really good point that he brought out. It's not about perverse incentive to make profits. Here we are here
Right.
for the patients, and that's the focus we should not lose. And
Right.
also, as you said, like bigger brain than mine, I think it's not one brain. It's not
Yeah.
the need. It's not a remit of a single brain to solve this bigger problem. I think it's a group of brains that needs to solve this problem, as you said, collaborate to solve this issue. And I think we can get there as a group. I don't think any single mind should be focusing on solving this problem. I think it's just not fair. And we'll get there. Finally, before coming to the very last question, this is second to last question. What advice would you give to professionals who are entering healthcare revenue management industry now?
I would say be curious. There's a lot of be curious and be a sponge. I have had the opportunity in a very, very unique career path that has given me a lot of exposure to different things. Having a toolbox full of process improvement is a great way to start in this industry because it is very complex and you have to ask the questions why. So I am Kaizen trained, so I'm not quite Kaizen certified. Didn't get there quite yet, but I'm Kaizen trained and I've actually facilitated several Kaizen events. Some of them were a couple of days, some of them were a full week. They're a lot of fun and they're very, creative thinking. Kind of that right brain, creative thinking, that curiosity, leading with questions. One of the activities that we do is the 5 whys. So when somebody presents a problem, you ask them why it won't work 5 times. And so having that curiosity, just that natural tendency to question and go, well, that doesn't seem right. That is going to get you farther than somebody that just basically memorizes how revenue cycles should work. Because I can give you in 3 sentences or less the way that it should work, but then that's not the reality. That's especially not where we're at in this day and age. You have to get creative. You have to think outside the box and you have to strive for better. You always have to be reaching for higher, reaching for the stars, that you can always improve. Absolutely. You should never sit still. It needs to be improved upon all the time because it is an ever evolving industry that we need to keep working on.
Essentially, if we want today to look exactly like yesterday, this is probably not the job for you. You got to learn, you got to adapt. Fantastic. I think that's the need of the industry. And again, the patients are also different. So when you're in healthcare, every patient is unique. Before we wrap up, is there any pitch for your company or pitch for an idea or something that you think is really important that we did not cover enough during our podcast? Is there something that you want to tell the audience, Megan?
It's really important that you empower your team, your billing team, with tools that they have to be successful. Giving them a list of accounts may work for some if they know how to, kind of filter those accounts and work more efficiently. But for the most part, a lot of billers are going to need to be guided. And so it does take handholding, not necessarily handholding where you have to say, now work this one, now work this one, but having a list or assignment of accounts that is tailored to what exactly you're looking for and want them to focus on, in addition to very clear policies and procedures. So giving your team the tools, the training. I'm really big on educating the billers, even on things that you would assume that they would know. So never underestimate, things that you think that they should know. Maybe you need to put out a training that has, what the fields are on a claim form. Maybe people don't really know what a CPT code is and what the importance is, but they've been in the industry for 5-6 years and there's this assumption and now they're too nervous to actually admit they don't know what that means. And so never assume that people know more than they do. Really give your team the tool that they need to be successful and efficient. And then it also shows that you're really you are investing in their future. You're investing in them. Revenue cycle can absolutely be a career. 23 years ago, when my job was to enter in Medicaid ID information when people sent in their Medicaid coupons attached to a statement, that was my job 23 years ago. And then now, I'm a vice president of revenue cycle. So you can absolutely make this a career. I do not have any college education whatsoever. I just had that curiosity and really a passion for the troubleshooting, the problem solving, the, really getting the team prepared, that education side of things. So I would say, really get your team prepared. And then I think my second piece is work really closely, and this ties back to that collaboration that I think we need to have with the insurance companies. Work closely with your provider reps. Use them to give you information on, claims that you have problems with, to reprocess those claims. Don't give up on that. Those claims don't say that they're, something that you're not going to collect on, uncollectible. Don't just write them off. Work with your provider rep. I've worked in hospitals where they had reoccurring services for patients, and typically on that service was on their pre-authorization list for the insurance company. One of them was Blue Cross, and they just sat down with Blue Cross and they said, okay, look, we perform hundreds of these a month. Out of those hundreds, 95% of them, we followed the process and we've got authorization. How about we try this where you no longer require a pre-service authorization for this because we have a good track record of doing what we need to do. And the insurance company said yes. So then we didn't have to. We didn't have to get a pre-service authorization for that particular service anymore. And then after a while, it just expanded to, kind of a whole suite of services. If you have a contract with the insurance, even if you don't, get on a good page with that provider rep, really work with them, and they'll help you. They'll help you move mountains if they can. I've had really good success with some provider reps, and they have been extremely helpful because when you call customer service, you're just going to get somebody on the other line that is probably about as educated on claims as customer service at a vendor, where not necessarily. You get some good ones, but then a lot of times they're going to tell you, oh yeah, you just do this, and then maybe that's not the case. So get those provider reps to advocate for you and work those claims and that sort of thing. So it's that collaboration with the insurance company that is just really important.
Great advice. I think your advice actually is it can be applied at a higher level as a leader, that you make sure that you're trained and then you empower your team to create their own path and find solutions, not rely just on the training, but also go beyond it and find new solutions and keep adapting. And how do you adapt? Educate yourself, and you have provided a resource in your industry, but I think we need to find our own resources where we can adapt it if it is a different industry. So this is overall a really good leadership lesson. Thank you very much for that, Megan. I think with that, we come to an end to our such an educational podcast today. And Healthcare Heroes podcast thanks you for being here, Megan.
Wonderful. Thanks for having me. This was great.
This was awesome. All right. Thank you very much.